Good morning. My name is Megan Clanahan. I am the co-owner of Houston Moms Blog. And today I have the privilege to bring to you Dr. Aly with UTMB Health. And he is a pediatric cardiologist. And this is Heart Awareness Month. I think most people know that February is the month of love, but also when we talk about everything heart related. But it's also Congenital Heart Defect Awareness, and specifically Congenital Heart Defect Awareness Week typically runs the 7th through the 14th through Valentine's Day. And we are going to talk today about congenital heart disease, congenital heart defects, and we are going to go and get started. And I have a personal story that I'm sure we'll share. But Dr. Aly, thank you so much for joining us this morning.
Thank you.
Can you tell us a little bit about you, where you currently practice, the types of patients that you see?
Well, I'm originally from Egypt, and you can tell from my accent. I'm one of 10 kids. I made up my mind to become a pediatrician when I was 5 years old. After finishing medical school in Egypt, I came to this country more than 35 years ago, where I got a PhD from George Washington University. I did my pediatric residency in Pennsylvania in Hershey Medical Center. I did my fellowship in pediatric cardiology in Michigan Children's Hospital. I did practice pediatric cardiology in a private setting for a few years before moving to UTMB about 20 years ago.
Okay. So that sounds like mostly up north. So this cold weather is like not bothering you at all, right?
I'm used to it, but I'm not missing it.
Well, believe me, we all wish this would go away. I know it is miserable out there. So you practice down here at UTMB. So we're going to dive into everything about CHDs. So I can kind of tell you, well, I can tell you a little bit. So my daughter, Quinn, is 10 years old, and she was diagnosed in utero with a complex congenital heart defect. She has double outlet right ventricle, pulmonary stenosis, VSD, ASD, the whole kit group. And she had open heart surgery as a baby, 15 and 16 months old. And now we're monitoring for her pulmonary valve, which will eventually, it's working for her now. It will eventually need to be replaced. So that's my history with CHD. So Dr. Aly, tell us a little bit about what a congenital heart defect is. And just for those people who may not know, and maybe how many CHDs affect babies each year?
Generally speaking, when we talk about the heart, we talk about two different things. Number one is the heart as a pump, the structure and function of the heart. Number two is the heartbeat, which is the electric activity of the heart. That anything that affects the heartbeat or the heart rhythm is called arrhythmia. I don't think we're talking about it this morning, but we can if time allows. The other thing is the heart as a pump, the structure and function of the heart. The normal heart is formed of 4 chambers, 2 on the right and 2 on the left, and it has 4 valves, 2 on the right and 2 on the left. And it is connected to 2 major arteries, one on the right and one on the left. And it also connected to 6 major veins, 2 on the right and 4 in the left. Any defect in development of the heart or the nearby vessels is called congenital heart defect. It's usually due to an insult that takes place early in development, specifically in the first 6 weeks of gestation. And it usually progresses as the fetus develops in utero. And the congenital heart defect is the most common defects It affects about 1% of all newborns. So in the United States, we have between 40 and 50,000 newborn every year with congenital heart defects. And when we say congenital heart defect, it does not necessarily mean all of them will need heart surgeries. Only about maybe 1/4 of them will need heart surgery, and the majority of them are simple heart defects that usually either resolve on their own or do not need any intervention.
And I think that's such an important point. So we talk about big numbers. I mean, 40, 50,000 children. Likely, if you're watching this video, moms, you know of a baby or two babies or two children who have a heart defect. You know, again, not all stories are quite as dramatic as Quinn's, but it is still very much a reality. So you mentioned that it happens really early, typically almost like I don't know, this was how it was explained to me. I might be wrong, but like in most cases, it's just like a misfiring in development. I think some do have genetic causes, but that's not the leading of CHD. How are we detecting these heart defects? How would you know that your baby has a heart defect?
Let us go back. As we said, the heart defects are about 1% of, affects 1% of all newborns. So any pregnant woman with no risk factors has 1% chance of having a baby with congenital heart defect. If there is one affected child and the lady got pregnant again, the chance of having another kid with heart defect jumps by a factor of 3, so it'd be 3%. If she has 2 affected children, the third pregnancy will multiply by a factor of 3, it will be 9%, and so forth. So you multiply with every affected child, you multiply by 3 to see the chance of having another affected child. We don't know for sure what is causing the congenital heart defects, but we believe it is multifactorial. Multifactorial means the interaction between genes and the environment. And the environment can be high blood sugar, can be exposure to drugs, to medications, toxins, and a lot of times we don't know exactly what is causing it. If we suspect a congenital heart disease in a pregnant woman, they usually refer them to our fetal cardiology clinic. When we start scanning the baby's heart between 16 and 20 weeks of gestation, that scan is about 85 to 90% accurate in detecting heart defects. Of course, it's not 100% because it can over or underestimate the size of holes or the integrity of valves, but it is generally speaking between 85 and 90% accurate. But definitely the ultimate diagnosis is done after babies are born by echocardiograms, which the sensitivity is over like 99%. And we are usually able to diagnose most of these congenital heart defects by echo. In rare cases, we might have to do some other imaging, including MRI or cardiac CT angiograms to delineate the anatomy of some arteries or veins that we cannot clearly see by echo. And in very rare instances, we have to do a cardiac catheterization for ultimate diagnosis, which is, again, is very rare.
So I think that's a really important point about the anatomy ultrasound, that scan that we get 16 to 20 weeks. Because I think a lot of times as moms and parents, we look to that ultrasound as like, that's the one where we get to find out if it's a boy or a girl, right? Like that's the big gender reveal. And But we forget that during that, y'all are also looking for, signs of CHD or kidneys or livers, checking out and making sure that everything is functioning. So I would definitely, when you do your anatomy ultrasound, pay more attention than just gender, right? So
Well, my daughter just had a baby 2 months ago, and I did her fetal scan when she was like about 16 weeks pregnant. And as you said, she and her husband were very excited to see the heartbeat and to take a look at the baby's face. And honestly, I did not pay any attention to that. I was focusing on the heart structure and anatomy. I want to make sure all the chambers are there, all the valves, all the connections. And this is very important for us to pay attention to minor details, especially in the structure of the heart. And she was kind of amazed that she was very excited to see the baby face and baby heartbeat. And for me, I had no emotions about that. I was focusing mostly to get the anatomy scan of the heart and make sure everything is okay.
Yeah, you want to get that baby here safely, the great
That's
baby. Congratulations to y'all. That's so exciting.
Thank you.
And so after, let's say all of your scans and everything come out well, and you have your baby, are there signs that you need to look at your baby, after they're born, 12, 24 hours, 48 hours, of things that might indicate a cardiac event?
Well, that will take us to the different presentations of congenital heart disease.
Okay.
The majority of heart disease, as we mentioned, they don't present with any signs or symptoms because they are benign. And
Okay.
that's like 75% of the congenital heart disease. And they are commonly caught by physical examination of the pediatrician when they hear a heart murmur, which is an extra heart sound, or a minor change from normal. And that can be heard early in birth, after birth, or maybe after 1 or 2 years during early childhood. But for the significant congenital heart disease, which is about 25% of the total, we classify them into two major categories. The first one is the one that commonly present with what we call congestive heart failure. Those kids are pink, but they work hard to breathe, and they may have some shortness of breath, and that can affect their growth and development. Those are commonly caused by big holes in the heart or big communications between arteries or other causes. Those usually are treated with medications. There's a good chance that these holes will close on their own. But if they don't respond to medical treatments, they are likely to need surgery. And generally speaking, we try to delay surgery as much as possible to have better outcome for surgery. But generally, we try to do the surgery between 3 and 6 months on those kids who present, we call them non-cyanotic congenital heart disease. Okay. The other category of congenital heart disease is what we call cyanotic heart disease. And those kids present with cyanosis, which is a blue discoloration of the lips and mucous membranes and the skin. And this is a little bit more serious. And we have to do a quick intervention early in life. A lot of times we have to put them on some medications to make the blood circulation similar to the fetal life in preparation for heart surgery, which can be done in the first week of life. And many of those kids would need more than one surgery. As your daughter, you're telling me she had already had 2 surgeries, but we have other kids who will need 1 to 3 heart surgeries in the first 2 years of life depending on the nature of the cyanotic heart defect.
So what would you tell a parent, a mom who is being referred to you because um, there's a suspected issue? I mean, when we as parents hear that there's something wrong with a child's heart, automatically we go worst case scenario. So what do you tell your moms, your parents who come to you and they may have had a baby that was diagnosed or a child who they just heard a murmur?
Well, to simplify things, I usually tell moms, especially the new mothers, uh, whenever they hear the word heart defect, they got panicking. I tell them watch two things, feeding and breathing. If the child is feeding well and breathing well and is gaining weight, there is no urgency of doing anything. But if the child is working hard to breathe, especially while the baby is feeding, feeding, by the way, is it takes a lot of energy from the newborn infant. So if a kid has a heart problem that is affecting his ability to feed, that is a sign for us, is a sign of what we call congestive heart failure. And when we talk about congestive heart failure in this setup, is very different from the congestive heart failure that affect older people. For us, in this setup, the congestive heart failure, it means lung congestion or increased blood flow to the lungs. But if you look at the heart function itself, the heart function is either normal or supernormal. That's the complete opposite of congestive heart failure for an older person who has a heart attack. And in this case, part of the heart muscle is replaced with fibrous tissue, and the heart function itself is decreased. So we have to, even both of them have the same word, failure or heart failure, but the mechanism and the treatment and prognosis is completely different in the two setup. So in short, I tell the new parents, watch for feeding and breathing problems. If the baby is feeding well and breathing well and gaining weight, there is nothing to worry about at this moment, and let the doctor take care of the problem and listen to his advice, of course.
No, I think that's such sage advice, and we need that reassurance. That, and if your child is diagnosed with some sort of CHD, what can you tell them about the overall success rates of babies surviving CHD?
As we mentioned, about 75% of the congenital heart disease are benign or will resolve on their own. Specifically, for example, holes in the heart. For small to moderate size hole in the heart, about 90% of them will close on their own. For large holes, about 50% still will close on their own. So there is no rush to jump and talk about surgery or do any intervention on those patients. Will let nature take its course. And a lot of times, many of those kids would not need any intervention or surgery. We keep the intervention or surgery for those who are actually in need or to prevent something bad from happening in the future. But overall, the many of those kids, or the majority of them, will resolve on their own, and the fraction that will need in any intervention or heart surgery, the success rate is very high. It is over 95% in most of the cases.
I think that's amazing. And I think that shows how far awareness has come in, funding, so that success rates of surgery are improved, that you all even have pediatric cardiology, because like you said, it's totally different than the adult side. And we need the pediatric who understands how different and how teeny these little hearts and vessels, and we talk about it, but it's literally we know it's minuscule. Um, I have a question just randomly came to me. So we hear about, like, sometimes I will see free screenings go up for athletes, maybe, 13, 14, 15 years old, and they will do free heart screenings for potential heart problems. Because it seems like occasionally we hear of an otherwise healthy young person, maybe dropping on a football field. What is your particular view on heart screenings for those specifically involved in competitive sports?
This is a very important and sensitive topic, because every now and then we hear in the news about a competitive athlete who drops dead in the field or in a competition. And a lot of school systems adopted doing screening programs on their own, and some of them got funding to do an EKG for screening many of those kids. Well, if the EKG is read by a professional pediatric cardiologist, I have no problem with that. But what happens is many of the local physicians rely on the computer interpretation of the EKG, or other physicians who are not familiar with pediatric cardiology EKG interpretation. And that creates a lot of anxiety in families, and also create a lot of unnecessary testing. But for kids in general who have a strong family history of heart disease or sudden death from cardiac causes younger than 50 years of age, those need to be referred to pediatric cardiologists. Those who have symptoms, specifically chest pain with activity, that also is a red flag for us. As far as I know, the American Heart Association and American Academy of Pediatrics at this moment does not recommend screening EKGs in schools. Even many schools adopted that protocol, but they adopted the history and physical examination for all kids before sports participation. If there is a concern, to refer them to pediatric cardiologist who is familiar with those patients, and that probably will be the best way. When I was in Michigan, I used to do pre-participation screening in high school, and I personally caught like 2 congenital heart disease in some kids, and the 2 cases required surgical intervention.
Wow.
So it is important, but I don't want to create a lot of anxiety among families, because most of the kids will do fine. But if there is strong family history, or the teenager has any symptoms, they need to be seen by a pediatric cardiologist.
Such sage advice. I've always wondered, and obviously we want to prevent as many deaths as possible, but I think you brought up some really valid points on who's reading these, because I know just from my very, very limited only parent knowledge, which is dangerous sometimes, that Quinn's EKG does read differently, needs to be read by a pediatric cardiologist, because she will always have these weird little, I call them blips, but because her heart was opened up, and so her rhythm looks different. So really great advice there. I don't want to take up too much more of your time. Is there anything else that you would like to leave with our parents, our moms, as it relates to congenital heart disease?
Well, as I mentioned, we can summarize a few points. Number one, that the congenital heart disease is the most common congenital defects in general. It's about 1% of all newborn. the majority of congenital heart disease are benign and do not need intervention or surgery. And for the small minority that do need intervention or surgery, the outcome is usually very favorable with success rate over 95%. And the majority of those kids will enjoy normal life or near normal life. And last point, they need to follow up with a pediatric cardiologist as recommended.
Great summary. And I can't tell you, as a heart mom, and it's good for us to have that piece and those words, because we can get, I get alarmed every year. We have her checkup, and it's good to know that overall we're probably going to be okay. And so I think, pediatric cardiology, you will forever have my gratitude for serving these children and helping them start to advocate for themselves. So once they can transfer into an adult cardiology, which is a whole other discussion, I know. But you are doing amazing work. So thank you for what you contribute to this community and keeping our babies safe and our kiddos safe. Congratulations again on your grandbaby. And thank you so much for joining us today. I really appreciate it.
Thank you.
Have a great day.
Thank you again.